السلام عليكم ورحمة الله وبركاته. أهلا بحضراتكم جميعا. كل سنة وحضراتكم طيبين. يعني عيد سعيد. ربنا يتقبل منكم جميعا الصيام والقيام وصالح الأعمال. احنا النهاردة في أمسية ليلة العيد. معانا واحد من الطيور المهاجرة، ابن الزقازيق، أخونا وحبيبنا في الجزء المصري اللي في أمريكا. يعني يمكن أحمد السباين كلينيك بتاعته هناك اسمها ايجيبشن سباين. فيعني دكتور يسري، ممكن حضرتك تقدم بقى يعني اخونا الدكتور احمد.
ليا الشرف يا احمد، من احسن السباينال سيرجنز اللي انا قابلتهم في حياتي، وكان ليا الشرف ان انا في فتره ما ان انا ابقى هيز منتور، واللي قعد معايا كنت انا مشرف على رساله الدكتوراه، كانت عن اول سكروز في السكوليوزس، الديفاتيك سكوليوزس. عندنا احمد قدرنا نجيب له تشانل مع الدكتور خالد كبيش، وبعد كده قعد تقريبا سنتين في جون هوبكنز، يمكن اكتر. عندنا احمد يعني شق طريقه في الصعب. يعني احنا دايما the surgeons in US start in a university or in a hospital, and the end of their career they go private. بس احمد started the other way around. He started as a private spinal surgeon، وده حاجة من الحاجات الصعبة، ان انت عايزة قوة جامدة علما وجراحة واكسبيرينس عشان تقدر اول ما تشتغل برايفت، وتشتغل برايفت ورك مع الانشورنس كومبانيز اللي هي بتبقى صعبة قوي انها توافق على اي حد سباينال سيرجن بالذات، ان هم مش عايزين مشاكل، عايزين ايزي ورك، وعايزين حد يعمل لهم الشغل كويس. فليا الشرف ان اقدم دكتور احمد سالم. واحمد قول لنا ليه سميت البرايفت ورك بتاعك او البراكتس ذا ايجيبشن سباين؟
شكرا جزيلا دكتور يسري ودكتور محمد خطاب على المقدمه الجميله دي. انا اتمنى ان انا اكون عند حسن ظنكم. يعني انا بدات طبعا في الاول في الزقازيق، وكان ليا شرف طبعا اكيد ان انا اتعاملت مع الدكتور يسري واشتغلت معاه واتعلمت منه كتير جدا. هو اكتر واحد اثر فيا، ويعني خلى السكيلز بتاعتي مختلفة عن أي حد أنا كنت معاه في نفس الوقت. بعد كده الحمد لله برضو بفضل ربنا ومساعدة دكتور يسري ومساعدة جامعة الزقازيق قدرت أخد البعثة وأروح أمريكا، واشتغلت مع الدكتور خالد كبيش، واحد برضو من أحسن الجراحين اللي أنا شفتهم في حياتي. اتعلمت منه كتير، وده خلى برضو يعني غير مهاراتي وغير الفكر بتاعي في الشغل بطريقة كبيرة. مش عارف الصورة راحت، انت شايفيني ولا؟
لا شايفينك يا احمد، شايفينك
تمام. بعدين برضو عملت فيلوشيب تانية في اوريجون، ونقلت من كذا مكان لحد ما وصلت في اخر المطاف ان انا اشتغلت مع حد في إلينوي. وبعد كده انفصلت وبدات ان انا افكر ان انا ابدا شغل لوحدي، والحمد لله ربنا كرمني. وطبعا ده بفضل يعني كل السنين انا عملتها مع الدكتور يسري، الدكتور خالد، الدكتور هارت في اوريجون. خلى المهارات مختلفه، وخلى الحمد لله عندي سكيلز وعندي يعني حاجات اقدر اقدمها للناس هنا، وهم يعني بيابريشيت ده. عملت الكلينيك وسميتها ايجيبشن سباين كلينيك لسببين. السبب الاولاني طبعا ان انا معتز جدا ان انا مصري اكيد. والحاجه الثانيه ان المكان اللي انا فيه لحسن الحظ بالصدفه اسمه ليك اوف ايجيبت، فهو جات كده. يعني في مدينه حتى اسمها كايرو في المكان دوت، وكان في بعض الاماكن زي الالكتريك كومباني والترين كومباني هنا اسمهم ايجيبشن، فانا قلت خلاص يبقى هي ايجيبشن. والحمد لله مشي الاسم. ناس كتير في الاول قالت لي ازاي انت سميه حاجه ثانيه، عشان انت كده ناس هتعرفك ومش عارف ايه ممكن ما يجولكش. انا اصريت وقلت لا، انا هكمل زي ما انا، وان شاء الله ربنا يسهل. والحمد لله.
الحمد لله. يعني شكرا يا احمد كمان انك ذكرت الزقازيق والمكان اللي انت اتعلمت فيه، وما نسيتش فضل اي حد. وده دايما اللي بنقوله ان الكانديد مهما كبر هيفضل فاكر الناس اللي ساعدوه في حياته، عشان الاجيال اللي هي تفضل فاكرانا وهم المنتورز الاجيال بعد كده وهكذا. شكرا يا احمد. وهتقول لنا ايه النهارده؟
والله انا عندي شويه حالات ظريفه. يعني انا كنت عملت انا يعني بعمل طبعا كل حاجه في deformity, degenerative, cervical ولامبر. فمن ضمن الحاجات اللي هي very يعني difficult وناس كتير بتتعامل معاها هي الجنكشنال failure في السيرفيكال او في اللامبر سباين، سواء ده كان degenerative او سواء كان deformity او. فعندي 3 حالات هقدمهم ظراف قوي، واحده سيرفيكال وفي حالتين سكوليوسيس عملتهم وحصل معاهم بروكسيمال جانكشن فيلير والحمد لله صلحتهم والامور يعني ماشيه كويس. فهنمشي واحده واحده كده في الحالات وان شاء الله نعرض الاشعه وتبقى كويسه يعني.
Okay, but Ahmed, kindly start the presentation in English because we have some attendees from foreigner countries. So to enjoy the talk.
Inshallah.
Thank you, Ahmed.
Let's see here. My name is Ahmed Salim Mohammed, Egyptian Spine Clinic in Southern Illinois. I will talk about a group of people. They live here in Illinois and mostly in the US. Their name was Amish. The Amish group, though, is a traditional Christian church fellowship people with Swiss and German origin. They follow rule of the church. They, for all day living, include prohibition of and limitation of use of power lines, electricity, telephone, automobile, as well as the regulation on clothing. They make their own stuff. They don't buy commercial insurance. If they have any medical problem, they go for a private physician. They pay cash. They don't participate in the social security of the country. At the same time, also they practice non-resistance, which means they will not perform any type of military services. They value the rural life, manual labor, under all aspects, and they believe in God, and they're very, very nice people. I have a patient that I did surgery on his wife about 5 years ago. Was very successful surgery. The man told me immediately after surgery, within a couple of weeks, that I gave his wife back to him. So he was very, very happy. Again, I left the practice I was in 4 years ago and I started my own business. They have no internet connection. So they spent like 4 years looking for me for treatment until they found me. And again, those people live all over the states. In Illinois, again, they have their own life, their own business, they make their own clothes, food. Even they travels for the snow, they have their own stuff. So this gentleman is about 75 years old gentleman. He has had ECDF C5-C7 15 years ago. That was done in Mexico. As I mentioned before, they pay cash. So at that time, they fly to Mexico and they pay for the surgery and they come back to the US. A lot cheaper for them, more, a lot easier and, different than they have surgery done in US. So the gentleman came to me again after, they found me after 4 years, complaining of neck pain, arm pain, numbness, headaches, some balance problem, lower back pain, leg pain. After examination, I ordered MRI and CT scan, and this is the picture of his cervical spine. He had again fusion C5-C7 15 years ago, very solid fusion. The blade is almost covered with bone. Above the fusion, there is again, as you see, retrolithiasis of 4/5 with a spinal canal stenosis and flattening of the spinal cord. So we discussed different options, and again these people don't they pay for their treatment. So he asked me for the final treatment. Okay, so we discussed the surgical option, and we decided to do an ECDF above the fusion to reduce the erythrolysis, take the pressure off the spinal cord, and hopefully relieve his symptoms. So he signed up. He paid the hospital, paid me cash for the surgery, and this is what I did. He was able to do a perfect, complete decompression above the fusion. I did not touch the old hardware because it was really covered with bone, and the risk to do that is to cut the plate, remove the bone, and high risk of vascular injury or esophageal injury, which is a catastrophe. So I did the standalone cervical discectomy fusion with proximal plate and screws. And this is how it looked like from the front. Immediate relief of his symptoms. The headache is gone. There's no numbness in his hand. Pain is very minimal. Very happy man again, like his wife. And again, he was one of my best patient I ever deal with. They really appreciated what I did for them. They actually started to send me more patients from their community, because once they trust someone, they just direct their attention. His whole family. I saw his daughter, I saw his grandson, some of their community members as well. So that was a very successful surgery, as we discussed before, in this kind of population, and they're very happy people. Any questions?
Great. Thank you, Ahmed. So case by case, and we'll ask the attendees to ask questions or deliver comments. First of all, we have a greeting from Professor Muhammad Al-Soufi. Professor Soufi want to say something to you. Professor Muhammad, Dr. Muhammad Al-Soufi، كل سنة وحضرتك طيب.
طيب يا حبيبي.
اتفضل يا بيه.
وانت طيب يا حبيبي، وسلامي للدكتور يسري بيه واحمد حبيبي واخويا الصغير.
طبعا. تسلم دكتور صوفي. يعني دكتور صوفي برضه من اساتذه الزقازيق العظام اللي انا اتعاملت معاهم، و ليه دور كبير وتاثير عليا كتير قوي في حياتي من ساعه ما بدات طبعا.
شكرا احمد، انت اخويا طول عمرك.
كل سنه وحضراتكم طيبين. مشاعر جميله كلها طبعا، والحمد لله ان actually thanks for the new technologies that really the world become a small country. We can see Ahmed, which is thousands of kilometers away from here. Ahmed, regarding your case, it is a quite interesting case. May I ask you, what is the add value of zero plate or this cage in comparison with the stand-alone cage, not anchored cage, conventional cage? Is it really differ in managing the adjacent level pathology with zero profile cages, anchored cages?
Well, this option is really a good option for proximal junctional failure, especially if you have a hardware below, like in this case. It is a lot easier to save time, save blood loss, and avoid any further injury or further damage to any of the soft tissue around the area here. Especially this guy has a previous surgery in the neck. He decided to go from the same side. All the scar tissue you deal with, if you try to remove the hardware from the previous surgery, there will be a complication. Minimizing that is to do that option, which is standalone spacer or standalone fusion. I always use a 0B or natural 0B, actually with allograft. There's a different type with beak allograft, beak 0B. I used PEEK in the beginning, but then I found that very good result with the natural 0B, which is an allograft. I'm not sure if it's available in Egypt or not, but fusion rate is a lot higher. I never had any problem with any one of them. No failure. So far, I've done over like 300 cases of natural 0B, even single level, 2 level, 3 level, or approximal like this one. So it's very, very easy.
In Egypt, we have PEEK Prevail. We don't have 0P. We have PEEK Prevail. But regarding the cost, it is triple the price of the conventional or ordinary cage. So that's why we can put only cage, standalone cage, instead of using PEEK Prevail or 0P.
I found also with the the natural 0P, or the problem with swallowing is almost zero. I've never had anyone complain of swallowing issue after surgery. However, like as with all the cervical fusion or the discectomy fusion, there is about 75% of the patient complain of discomfort when they eat or drink for the first couple of weeks. And this usually go down to about 10-15% after 2 weeks. With 0P or I found no complaint. All my patients was very happy. There was no problem with swallowing issue at all. They eat or drink immediately. I keep them on soft diet for 2 weeks just in case, but no issues.
Okay, is there any difference between the different types of bone graft and the cage? This is a question to you, Ahmed, from the attendees. Can you apply graft only without cage, and the rate of union is accepted or not?
Well, the rate of union is very high of course, with an autograft. If you take an iliac crest autograft, this will be, very high. Second to that is a natural allograft. The PEEK has a little bit higher rate of non-union. However, also with the non-union, it's not painful most of the time. I think for my hand and with what I have, natural 0B with allograft is very effective and very successful.
Okay, Professor Maziad, do you have a comment here, Professor Maziad?
Yes, thank you, Dr. Muhammad. Thank you, Dr. Ahmed. It is a nice presentation, but I didn't see the MRI before surgery. You present us the case without MRI to show us the disc above the fusion. Number one, did you consider this an adjacent segment disease on top of the fusion or not? Number two, if the patient, I want to finish my talk and you answer,
sure,
please. The cage is an excellent one. This is the cage which we can call it stand-alone cage because it has its own fixation. Stand-alone means it is fixed, it is stable. After you insert it, doesn't need a plate on top of it, or doesn't need posterior fixation to give additional stability, especially if it is multiple levels. So this is the cage to be considered a stand-alone cage. Cage plate is another stand-alone cage. But cage alone, multiple level up to 4, without plating, without screw fixing it to bone, is not a strong montage to stand-alone. So your cage is excellent, your technique is excellent. My comment is, if this patient come after 3-4 years to you with another level, will you do another cage for him, or what is your suggestion in case he may have other problem with the near future? Thank you. Congratulations for your case.
Sure. Thank you, Dr. Maziad, for your comments. And I would consider this case as an adjacent degeneration above the fusion. The incidence of failure or degeneration above the fusion happen after 5-10 years. There is a chance about 25% that people will develop area of stenosis or degeneration above the fusion or below the fusion. In this case, yes, this gentleman had surgery done 15 years ago and slowly, progressively developed degeneration above the fusion with some sort of instability with retrolithiasis above the fusion. So that would be considered a proximal degeneration and proximal junctional stenosis as well. The second question, a standalone cage with or a spacer or allograft with a blade attached to it, which what I used here, is very stable. And that's in this case, I was able to reduce the retrolithiasis. I was able to open the space around the nerve and take the pressure of the spinal cord using the same technique. If he comes back in about 5 years again, I would do another one above. If I see the pathology in the front, then I will definitely go from the front again and do another level of a standalone fusion. I've done 3 levels of a standalone fusion, and it is very stable and it is very successful. I would not do this if the patient has noticeable osteoporosis or difficulty to keep the hardware in place. I've seen some failure if you do that in someone who's osteoporotic. Bone quality is very important, especially with a standalone cage. And it is really indicated in such cases. Like this man has the previous fusion that I didn't want to take the hardware out. I didn't want to disrupt soft tissue with the scar tissue and all that stuff. So that was a lot easier for me and a lot easier for the patient. He's 75. He got out of the hospital the same day. He went home. No problem at all.
Okay, thank you, Ahmed. Let us go for the next case.
Sure. This is a 60-year-old female patient. She works in a company that manufactures tires. She was tire tech in a tire company, and she complained of chronic neck pain, headaches, gradual loss of fine movement, especially with her criteria of job. So she manual and she left, she bend, she twist, and she rotate tires. So she started to lose some of her movement. Complained of difficulty balance, frequent falling, and bladder bowel dysfunction. She also was diagnosed with leukopenia. Her white count was about 3,000. Also was diagnosed with osteoporosis. So she came to me with mainly lower back pain first in the beginning. So we did an MRI, and again, we found scoliosis, we found multi-level degeneration, and the lumbar spine. This is her X-ray, also double curve. This is her sagittal picture of the lumbar spine with, again, multi-level of degeneration, stenosis in the lumbar spine. Going into the cervical spine, again, also the curve extend up to the upper thoracic and the cervical spine. MRI of the cervical spine was showing again multi-level of degenerative spondylosis, stenosis with spinal cord pressure that was between 4.5, 5.6, 6.7, with anterior lithiasis of 6/7. Again, as you see from the X-ray, collapsed disc, straightening of the cervical spine, multi-level of degeneration. So she was eager to have something done because, again, she was losing function, losing her hand function, frequent falling, and she said, I need something to be done, otherwise I will lose my job and all that stuff. So she went to another surgeon in St. Louis, and she signed up for surgery. He took her for the surgeon the same day. They canceled the surgery because of her white count was very low. So she came to me after that, And again, we discussed all the options, we discussed the risk, and she signed up for the surgery, and we did 3-level ECDF, anterior cervical discectomy fusion with instrumentation, plates and screws, and she did very well. Surgery went, straightforward. Given the low count of the white BCs, again, there was some risk of, developing infection or failure. So she understood that before surgery, and she said, she will take the risk. Everything went straightforward. 2 months later, she came back again with another problem. So she started, after she recovered from the surgery, she was doing fine. There was no problem with, hand function, gained more function back. Still has some weakness in her hand. Over the 2-3 months after surgery, she started to develop more balance problem, and she came to me with walker. So decided to do a CT scan to see what's going on, and this is what we found. So she fractured about below the fusion. We did, in addition to the spondylolisthesis, or the anterior listhesis of 6 over 7 collapsed a little bit, and again that created some sort of stenosis below the fusion. Yeah, sorry about that here. I didn't mention, I did not, I'm sorry about that. There was no, so we decided to go from the back. I did her posterior, actually this time, a decompression fusion with instrumentation, extending from above the fusion to 2 levels below. So I went from C4 down to T2. Again, take the pressure off, did laminectomy, posterolateral fusion with instrumentation. Did very well. She improved after the surgery again. She was able to walk back with a cane. That's what improvement from walking with a walker, then walking with a cane, and she was very happy about that time. Knowing that she had a scoliosis in her, thoracolumbar area, we were planning to do her lower back surgery at about 3 months from the next surgery, so we were delayed about maybe 3 months after. So 6 months later, I took her back for her lower back surgery, and we did again multi-level decompression fusion with instrumentation, tooth S1 with sacroiliac fixation. She did very well with that, and then also a couple months later, she developed another fracture above the fusion in the lumbar spine. So we took her back. I removed the screws at that vertebra because the pedicle was broken on both sides. Extended the fusion to T10. Augmented the vertebra of T10 and T9 with cement to avoid further fracture or further failure. 3 months later, she developed that the screw was cutting through the upper end blade of T10 again. But this time was not painful, and there was no change in the angle. There was no focal kyphosis like we seen in the first one after the initial surgery. So we decided to just watch that. I put her in a brace for 6 weeks just to maintain the position and at least keep everything in place and avoid further failure. And she continued to do the same. This is I've followed her up for about a year now. The screw hasn't moved. There's no change in her balance. She still walks with a cane, unfortunately, but she gained some of her function that was lost before surgery, and so far she's happy.
Okay, thank you, Ahmed, for sharing your experience. So do you believe that the most important lesson that we learned from this case is respect the osteoporosis? Do you believe that all these complications and failures are due to the osteoporosis?
Well, yeah, there's many factors that affect the long fusion in the lumbar spine or even the cervical spine. Osteoporosis is a very important factor. And for all my patients, I try to get a DEXA scan, especially if they're, 50, 60, 70. I get DEXA scan for them to make sure we're not missing anything. At least we minimize risk of failure if it happens. Again, old age, women, osteoporosis, long instrumentation. These are risk factors for hardware failure. And it happened in her twice, and every time we were able to fix it.
Okay, Professor Sufi, kindly deliver your question to Ahmed. Dr. Sufi.
Why Ahmed not to go? Ahmed, why not to go posterior decompression and fusion from the start?
Which one? The cervical?
Cervical.
For the cervical spine, yes, Ahmed.
Yes, so she fractured at T7 and at C7, and it was extremely difficult to go from the front. So I went from the back, and I did a posterior decompression at that area where the spondylolisthesis is, and the fracture at C7, and extended the fusion down to C2. So I did a complete laminectomy of C4, C5, 6, 7. And I did an instrumentation from C4 down to T2.
Why Ahmed from the start instead of ACDF?
From the start, yeah.
So
actually, yeah. When she came to me, the problem was mainly in the front. All the disc bulge and herniations with C4, 5, 5, 6, 6, 7. And there was nothing to do, or at least to go from the back. I went from the front first, and this is always my approach, as to save the back until we need it. This is what I did. So I did an ECDF C4 to 7, and that was able to take the pressure off and to gain her function. Unfortunately, because of her osteoporosis and her other comorbidities, she fractured below that. And again, she came back to me. We found the fracture, we diagnosed it, and we did the treatment from the back.
Okay, Ahmed, can we see the lateral X-ray for the patient, the lateral X-ray of this patient again? For the lumbar spine.
Okay.
For the lumbar spine. Maybe for this patient as well, for the cervical, I will be with Professor Sufi opinion. Maybe I will do posterior laminectomy and lateral mass fixation, especially in osteoporosis, and the screw purchase, and the stability will be much better than anterior. Plus, it is not kyphotic, it is straight, more or less. Plus, the discs are collapsed. So maybe I will go with Professor Sufi opinion. Regarding this lateral X-ray, we have a comment from Dr. Muhammad Salman. Dr. Salman. Dr. Muhammad Salman, kindly unmute yourself. Dr. Salman, kindly unmute yourself. Unmute yourself, Dr. Salman. You are self-muted. Press on the microphone. Dr. Salman, you are self-muted. Yes. Kindly deliver your comment.
Hello.
اتفضل احنا سامعينك بس علي صوتك.
I see the X-ray view that most in the compensated position.
Muhammad, we cannot hear you. It is
I
really
can't
hard
hear
to hear you.
You you with me, Muhammad?
Yes, اتفضل يا محمد، اتفضل، كل سنة وانت طيب، اتفضل.
Dr. Ahmed, I see in the
Yes.
X-ray lateral view that the correction of the sagittal profile of the patient is corrected in the compensated position. And most of the lordosis, as you know, that as the L5, if you are not correcting the L45 and L51, you may have junction problem, and this is one of the factors.
I think I got what he wants to deliver. Ahmed, he asking about the distribution of the lumbar lordosis. You know, 2/3 of the lumbar lordosis came from L4-5, L5-S1 levels, and in your case, you regarding the distribution of the spinopelvic parameters and the lumbar lordosis, we couldn't achieve this harmonious distribution. That is the cause of this junctional failure.
You mean in the
What's
lumbar
your
spine?
comment? In the lumbar spine, yeah.
I don't understand quite the question. Can you read that again, please?
Okay, he is asking about the distribution of the lumbar lordosis.
Okay.
2/3 of the lumbar lordosis came from L4-5, L5-S1 disc.
Yes.
And here we didn't follow this rule. That's why we had PJK, proximal junctional kyphosis or failure for the patient.
Well, I think if you look at the initial X-ray for lumbar spine, let me bring this first here. So this is the MRI for her lumbar spine, and she was, you know, really kyphotic, and I think there's no lumbar lordosis at all in this picture. So she's very straight, and she had the severe degeneration at 4-5, 5-1, in addition to the scoliosis. So again, if you look at the AP picture, there's retrolysis, there's lateral lysis of 3-4 and over 4-5 as well. And looking at the lumbar picture here, I was able to correct that picture. So we have a very good lordosis here. Sagittally, she was very well, I didn't see any problem with sagittal imbalance to increase the risk of her fracture. I think the main problem was because of her osteoporosis, and maybe also I stopped at L2. That was not the right place to stop, especially with her bone quality.
Okay, so we can consider that it is mainly due to osteoporosis, plus or minus mismatch between the distribution of the lumbar lordosis. Ahmed, do you use long film for your cases, long standing?
Yes, definitely, yeah.
For your cases?
Yeah, I do get all the, for all cases, I usually check for any deformity. So I get standing film for all patients, even if they have this, just one level of degeneration. I get a standing AB and lateral. I don't do any bending unless I decide to do surgery. So AB and lateral standing film with lumbar focal film to make sure, there's no other factor that would affect any surgical decision.
Okay, Dr. Ahmed Marziban.
Assalamu alaikum. Thanks a lot for this webinar. I ask about with patients who have tendon stenosis, cervical plus lumbar stenosis, and both need operation. Is there a general consensus regarding with which you need to start?
Okay.
Do you mean like because he has the cervical problem and lumbar problem at the same time?
Yes. And
Yes,
you need to
definitely,
operate
definitely.
on both of them.
Right. So you know, all the time whenever I see any patient that's just complain of lower back pain, I do a full exam. That's number one. Number two, if I find anything abnormal in my exam, I would definitely check the cervical spine. If I find anything in the cervical spine, this is a priority. I do the cervical spine before I touch her lumbar spine. The main reason for that, number one, you know, to put a patient on the table for about 6 hours for a scoliosis surgery, knowing that they have a cervical problem. We've seen a lot of problem before that they may develop damage to the spinal cord or problem, you know, no need for. Like I seen patient during my fellowship who went for hip replacement and nobody checked the cervical spine. He have rheumatoid arthritis. They put them to sleep, manipulate their neck, put the tube in, very straightforward hip replacement. They woke up, they were supposed to stand up and walk. There's no function in the lower extremity. So what happened is during surgery, they caused more damage to the spinal cord because of, you know, they misdiagnosed a cervical spine problem. So all my patients, they come in for evaluation. I evaluate clinically, radiologically for cervical lumbar spine. If I find anything in the neck, then I would do surgery on the cervical spine first before I touch the lower back. Yes.
Totally agree with you, Ahmed. Plus, you know, always I tell my patients the cervical spine is the root. And if I will correct the root, maybe the branches distally will improve as well. So let us start by the more dangerous and more affected pathology in the cervical spine. It may help in the other pathologies. Dr. Salman, do you have another comment? Dr. Salman, kindly unmute yourself. Dr. Salman? Dr. Salman? Dr. Salman? Dr. Marziban again?
Yes, I want to ask specifically about the same question when we have both levels of stenosis, but on a simple form. When you have a patient with lumbar stenosis, 1 or 2 levels, and significant claudication, and at the same time, you have 1 or 2 levels cervical stenosis, and the patient is complaining mainly of sciatica. Would you think the same way you would go first for cervical?
Yes, I would. I would go for cervical first. And this, as Dr. Khattab said also, you know, some of the lower back pain could be coming from the neck. I have patients, they come for me, lower back pain, they have no problem at all in the neck. And then we did an MRI, found severe stenosis. We did their neck first and complete resolution of the lower back pain after surgery. Even some of them I didn't have to do in lower back. I have patients, they have immediate improvement of the lower back pain after the cervical spine is decompressed. I definitely will go with the cervical spine first for the 2 main reasons we mentioned here. The one that this is that could be the main source for the lower back, or could be part of the lower back problem. Second, because of if you plan to do lower back surgery and a patient with a cervical spine problem laying in their face for about 2-3 hours with all that pressure, that can cause more damage to the spinal cord during the surgery.
Ahmed, do you use neuromonitoring? Neuromonitoring intraoperative?
I do neuromonitoring for all the cervical spine cases. All instrumentation lumbar spine, definitely I would use neuromonitoring, yes.
Okay. In patients with multiple lumbar stenosis, about 25% of these patients have asymptomatic cervical spinal canal stenosis. This is a comment from Hamdan Abdulrahman. Okay, if the patient is completely asymptomatic, you may manage the main pathology, Hamdan. but we were discussing if we have both pathologies. And I do believe really actually some surgeons, if you are fast enough, you can manage both at the same at the index surgery. You can manage the cervical one, starting by the cervical one, and the lower lumbar one at the index surgery.
I totally agree. Yep.
Okay, Ahmed, can we continue with the next case?
Sure. This is also another very interesting case. 52 years old female patient, had long history of domestic abuse by her husband, beaten several times, and always ignored. And she came with a chronic, severe neck and lower back pain. She came to me with her son, walking with a walker, difficulty balance, frequent falling every day, losing bladder control, hand numbness, weakness, miserable lady. And, she never seen anyone to diagnose her problem. They always say to her when she go to the ER that she's faking, she's not, she doesn't have any major problem. They never x-rayed her neck, they never x-rayed her lower back, because of the multiple times she went to the ER, and she was also afraid of telling them about the abuse at home. So being ignored for a long time, years and years, and slowly developed a progressive problem in her neck. This is her cervical spine looks like. She developed, again, multi-level of degeneration, stenosis, severe pressure on the spinal cord. This is how her axial cut looks like. There is no space for the spinal cord. It's completely smashed. Again, it's the back of the cervical spine. This is her lower back. Again, multi-level of degeneration and bulging disc, stenosis of the lumbar spine. There is no lordosis. You see, it's almost a straight lower back. Again, this is how it looks like from the front. Again, multi-level of degeneration, arthritis. And so on this case, I decided to do front and back of her neck because of the amount of stenosis, amount of pressure on the spinal cord, and her bone quality and her nutritional status was not that great. So to avoid failure, I decided to go from the front and then flip her and do from the back. So this is what I did. I think this picture is compressed here, but let me do this. I did posterior cervical spine first, I'm sorry, and then I went from the front on the same setting. So I did multi-level of laminectomy between C3 to C6 with posterior lateral fusion with instrumentation, lateral massive screws. And then I flipped her on her back, and I did the 3 level of discectomy and instrumentation with fusion as well. I was able to take the pressure off, create more room for the spinal cord, and stabilize her neck. That was very successful. Patient had marked improvement after surgery. She was able to lift her head up and sit up straight. She was able to walk, still walking with a walker, but she stated that the pain is completely different. The pain that she had for years is gone. Only surgical pain that was at that after surgery. 2 days in the hospital, she went home. She did great. And then also we were planning to do the lower back at 3 months. So she came back to me at 3 months after surgery. We did, again, multi-level of decompression, fusion with instrumentation. I stopped at L1 down to sacrum. and her bone was very strong. So I didn't find any, problem with stopping there. I had difficulty inserting the screws. Even I used the drill to make my holes for the screws. Everything went straightforward. 6-hour surgery. Stayed in the hospital a couple days, and she went back to the nursing home where she lived. When she went back, 2 weeks later, the caregiver took her to the bathroom, and she forced her sitting on the toilet, and she bent forward, and she fractured above. So the pedicle here, if you see the pedicle at L1 is completely fractured, both sides. The screw is loose. The patient came back to me with severe pain, crying, and again, we did a CT scan. We found that. We decided to take her back, stabilize that area, and extend the fusion above. So again, remove the screws, decompress the canal. There was a fragment from the posterior superior corner of the L1 pressing the spinal cord. So we removed that, and we extended the fusion to T10, augmented also the vertebra above T9 with cement, and connected above and below. Did very well. She's following up with me almost 2 years follow-up, very stable. She had no problem, and she's very happy.
Okay, thank you, Ahmed. What kind of bone graft that you use in long segment fusion like this?
I use DBX, I use local bone, and I mix them together, and I put on both sides. So the local bone I took from her, from all the laminectomy, all the, sometime I do aspiration from the iliac crest, and I mix that with DBX, and I use it both sides.
Okay. Professor Mazyad, do you have comments here? Kindly unmute yourself. Professor Mazyad? Professor Mazyad? Professor Mazyad? Dr.
Yes,
Mazyad?
my comment. Yes, Dr. Muhammad, thank you. I would like to thank the speaker, Dr. Muhammad from the USA, because he makes a correct decision in the cervical spine regarding the case he is presented to us now, because I found in the picture that the compression from the posterior part of the spine, the ligamentum flavum, and the posterior compression was very severe, besides the anterior compression, which was very high also. If he can do anterior first, this patient, when he lie here down on the operating table and operate on the cervical spine, he might find the patient paralyzed, like the case he is mentioned regarding the hip. So even he spoke about his technique, and he verbally said, I started anterior, then corrected himself, said, I started posterior. And the correct what he has done to start posteriorly in such cases. Then you can do the anterior decompression as second part of the operation. Thanks that he has done the operation posterior and anterior as the same session. This is excellent. Even if he divided the technique to posterior first, then anterior later on, we have to start with the posterior because it is more safe for this particular type of patient. Thank you, Dr. Muhammad.
I think this is the same question which is delivered by Dr. Sufi as well. Why starting with posterior in the cervical spine, not anterior? Ahmed, the same like
it is safe to start to do the compression posterior. Otherwise, we will be confronted with paralyzed patient on table immediately after surgery. So if the compression is posterior, you have to start posterior. And this is my recommendation in other session before. If the situation is very tight like this, You must go posterior and do spinal canal decompression, posterior fixation with lateral mass screws, then turn the patient to do the anterior job. If you have no equipment, tired, patient have morbidity, something happened, at least you have done good, correct decompression and stabilization. You can postpone the second stage. But if you start in the opposite direction, in these particular cases, you will lose the patient. He will be paralyzed simply by straightening the neck. You added compression by doing surgery and with correction of the situation to be more lordotic, then the compression will increase from behind and he will be paralyzed. Thank you for this advice for all of us. Don't forget it. Thank you.
Thank you, Professor Maziad, for your nice comment. Regarding Ahmed, regarding the anterior column stabilization in your cases, we didn't see anterior cages at all. This is a question delivered by our dear friend Brodzinski. Why you don't use anterior cages in your cases? They are osteoporotic and it may add value for stabilization and support.
Why don't, I'm sorry?
Use cages, Ahmed, anterior cages.
Well, I use cages, but it's mostly allograft spacer. What do you mean cages by, like metal cage or beak?
No,
or
beak or whatever. Most of the cases that you showed us in the lumbar spine, this last case in particular, only posterior constructs, screws.
You mean lumbar spine? Yeah.
Yes,
I do lumbar. I do the same. I do support from the front if I need to, but for like, for example, for scoliosis cases, you do a surgery for 6-7 hours, and you plan is to do T10 to sacrum. Sometime if I see severe collapse or severe kyphosis or spondylolisthesis, I do TLEF at the same time at 4-5 and 5-1. If I don't, then I would do stage, like I do the posterior first, and then later on, after 6 weeks or sometime 4 weeks, I take them back and I do anterior lumbar discectomy and fusion, and I use cages. Same thing like I did for the standalone cage. There is anterior lumbar standalone cage, L4-5, L5S1. I had very good support, and I, able to get a lot of lordosis doing this from the front as well. But I do, yes.
Okay, so your impressions that doing interbody cages at 4-5, 5-1 to decrease the incidence of pseudoarthrosis and achieve the much lordosis at these two levels. Okay, there is a comment delivered by Dr. Hamdan Abdulrahman from Germany asking about the hyperperfusion or reperfusion phenomena which can be anticipated after anterior and posterior decompression at the same time. Do you have this phenomena? You know it? Hyperperfusion phenomena or reperfusion phenomena.
But I don't have any problem with these people. This patient had the surgery front and back, and I am sorry, for back and front on her case. It took me 6 hours. Never had any problem with that. So.
Okay, Hamdan, we need to hear your experience from Germany regarding the reperfusion ischemia or hyperperfusion ischemia. Hamdan, kindly unmute yourself.
Usually keep the MAP above 100. If you keep the main arterial pressure above 100 all the time, you're unsafe. The blood pressure neuro monitoring at the same time. If you keep that in mind, that will save the patient for sure.
Okay, Hamdan.
Hello, السلام عليكم.
وعليكم السلام ورحمة الله.
دكتور محمد. It is recorded. الله يخليك دكتور محمد. الله يكرمك. It is recorded to be after in long-standing cases of cervical myelopathy with anterior and posterior compression of the cord. It is recorded if we decompress acutely posterior and anteriorly in the same time, to be to have a neurological deterioration after the surgery, after 1 day or 2 days. It is recommended to do stage surgery. 3 or the 4 weeks in between, anteriorly and then posteriorly, or the posterior and then anterior reconstruction. I think so. It is better for the patients in such cases.
Well, I think it depends on, you know, how fast you are and the anesthesia team with you, and you know, keep in mind again neuro monitoring and your keeping the blood pressure, keep the perfusion of the spinal cord. This will minimize the risk of any damage.
Okay. I have another question about adding a plate anteriorly over a long segment. We have fixed the patient posteriorly with massa lateralis or the lateral mass screws. Why we have to add the plate anteriorly in such cases?
So you mean augmenting the anterior cages with plate?
Yeah,
why?
it is already
And we have lateral mass posteriorly. Okay.
It is already fixed posteriorly, and why we add a blade anterior over the long segment with I think more complication anteriorly.
Okay, good comment.
Well, again, you know, doing the anterior portion of the cervical spine here is to, again, take the, you know, there was two parts of pressure on the spinal cord here, from the front and from the back. As Dr. Mezi had mentioned, we went from the back first to decompress the spinal cord and avoid, you know, any problem during the anterior surgery. Anterior surgery is to take the pressure again from the front and also to restore, you know, the lordosis of the cervical spine. So doing only posterior will not be enough to decompress and to restore the you know, normal alignment of the cervical spine. So back and front was the best option for this patient.
Dr. Sufi, kindly deliver your comment, Dr. Sufi.
I want to ask Ahmad about acceptance of failure from the patients.
Acceptance, I'm sorry?
Of failure by the patient.
Acceptance of failure. Well, you know, again, you know, when I see the patient first and we decided to do surgery, so I offer them the options, whether, you know, doing nothing or continuing an operative option or taking the surgical option. When we discuss the surgical option, if the patient decided to proceed with the surgery, I discuss with them in details all the complications that could be encountered with the surgery, including, you know, death, bleeding, infection, paralysis, loss of bowel bladder function, failure of the hardware, failure of the screws, requirement to take him for another surgery or redo the surgery. So they understand from the beginning, even before we do the index surgery, that there is a risk about 1 to 2% that this problem could happen and we might have to take them back. So they, you know, anticipate, or they have in their mind that there is, again, a chance of failure, which could happen with anyone, with the best hand surgeon all over. They have this kind of complications. When it happens, you know, they accept it. And again, they come to you, and if you diagnose the problem and you find it and you explain to them what happened and why that failed, and you again offer the option to correct that, they always appreciate what you do. But again, you know, explaining everything in the beginning is very, very important. You know, I don't make the life green for them. I just like, okay, there is this so and so and so and this risk of there. If you agree, we will proceed. They always, you know, again, read the consent and sign it, and they understand the risk and the complication that happen with any kind of surgery, and that's why they accept. So, you know, it is acceptable by the patient if you explain to them before surgery.
Dr. Yusri two weeks ago told us عكنن على العيان قبل ما يعكنن عليك، فانت تقول له كل complicated علشان ما يبقى جاهز يعني. أحمد مرزبان.
Yes, thank you for this nice case. I have two questions. First of all, regarding the cervical procedure, approve using posterior cervical laminoplasty plus the anterior procedure. The second question is, why didn't you use iliac fixation for this long segment fusion in the first place, starting at L1, and again in the revision surgery when you went up to the thoracic spine?
Well, laminoplasty is for cervical spine in this patient. There is, again, as you know, the indication for laminoplasty, and cervical kyphosis, as in this patient, is a contraindication. So laminoplasty is not an option here. Using an iliac fixation on this patient, again, as I mentioned, her bone quality was really good. She had, and again, had difficulty inserting the screws using, a drill to make holes. Using iliac fixation is designed to decrease the risk of pseudoarthrosis and failure on the lower part. I think also that she had sacroiliac. There was some sort of sacralization of L5, and that also gave her some sort of stability. So I didn't find the reason why do I need to put iliac screws here. I always do them, especially if the patient is osteoporotic or I feel that there is a high risk of failure down there. But her bone was really good, and I had no problem with that. So even after extending the fusion above, there was no failure down there. She failed only above because of the trauma she received from the caregiver.
Ahmed, are you aware with the GAP score, which is published 2 years ago in 2017 by the European Spine Study Group? Ahmed Al-Nai and his colleagues told us about the GAP score, which decreases the incidence of complication if you follow the distribution of the lumbar lordosis and the sagittal vertical axis instead of using the numbers which is written and described by Frank Schwab. Are you aware with this GAP score?
Well, I didn't use it before, but I'm happy to hear from you.
It is quite interesting. I will send you this paper. It is a really nice paper that considers the range and the harmonious distribution. Basically, it rely on, Russell types of lumbar lordosis to assess the patient lumbar lordosis and rely on the Russell types. I will send this paper to you after finishing this webinar. Dr. Brodzinski, Dr. Brodzinski, kindly unmute yourself and deliver your comment. Dr. Brodzinski. Dr. Brodzinski. Dr. Brodzinski. Any recommendation to avoid C5 palsy, Ahmed? Any recommendations to decrease the incidence of C5 palsy in such surgeries?
Well, again, C5 palsy is one of the most common complication, mostly with posterior cervical spine. ECDF, I've never seen C5 palsy with an ECDF. But with posterior cervical, it's quite very common, and I have few patients that they develop again posterior translation or shift of the spinal cord after you do a decompression, especially with C5 is a very short nerve root. It is very common to see, but they recover very well. So I had I think I had 3 patients. All of them completely recover within 6 weeks, and again, the recommendation is to just be careful with your decompression. where you stabilization in the screws. But if it happens, it's going to happen. I don't think you can prevent that from happening, but I would like to hear from Dr. Yusri if he has some more experience on that.
Dr. Yusri. Dr. Yusri.
Ahmed, I agree with you. It's more common.
Dr. Yusri, you are self-muted. Tfadal, Dr. Yusri.
Can you hear me, Ahmed?
Yes. Yes. Dr. Yusri, you are. تفضل Dr. Yusri.
Ahmed, I agree with you. It's common with the posterior, and you cannot. There is no way to prevent it. Luckily, it's recoverable. So yes, it's a thing I don't think you can prevent.
Right. It's very quite common, you know, and it's again, especially with posterior cervical decompression. I've seen it, you know, on my hand. Like I had 3 patients last year with the amount of patient I do, and they all completely recovered. I had most of them was unilateral, like one side. During my fellowship at Hopkins, and this was a very quite interesting story, Dr. Kubesh, you know, he doesn't do cervical spine as much. He always do, you know, complex, you know, spinal deformity from all over the country. But one day there was a patient that's related to one of the embassy from Egypt, and he flew from Egypt to Dr. Kubesh to do his neck. And he did the posterior cervical decompression fusion, C3 to C6. And that patient woke up next day with bilateral C5 palsy. And that was like, you know, a shock for, you know, everyone. It's like, but luckily, again, that guy completely recovered within 4 weeks. It is very quite common with the best, you know, hand. C5 is a very short nerve root with posterior decompression. Shift of the spinal cord can cause more pressure, and especially with someone who's have, you know, multi-level of spondylosis, foraminal stenosis, that can cause you know, C5 palsy. Again, as Dr. Yusri mentioned, it is recoverable, and I don't think it is preventable. But again, you be careful with your laminectomy and manipulation, and just pray for the best, I guess.
May I add something? Just do as well for aminotomy at 4-5 level in laminectomy cases. Generous for aminotomy. Professor Maziad, do you have comment? Kindly unmute yourself.
Thank you, Dr. Yusri and Dr. Ahmed and you, sir. The question, it is reported and to be reported and to be more common after laminoplasty. And if you remember, we are in Japan, Muhammad, when we, I've been asked about this question from our guest when on my arrival second day. Is it common in laminoplasty, cervical laminoplasty? It is common and reported like that. And it is the anatomy, because the spinal cord itself makes some sort of traction in this short, narrow place, C5. And the answer is that to do foraminotomy on the C5, to be generous in your foraminotomy, and they reported it in cases you operate on the opposite side by doing the hinged laminoplasty. You might find it in the side which you didn't operate on it. So it is mechanical expansion of the spinal cord causing traction. This is the thing which is more recoverable, because you didn't hit the nerve. It is the mechanics of the expansion, dorsal expansion of the spinal cord, pulling on this nerve. So if you make the track of this nerve wider by doing intentionally narrow, widening up the foramen, you can reduce the incidence of this after laminoplasty in particular, and of course laminectomy as second option or second surgery, what can cause this C5. But the thing which is unavoidable is related to the expansion and the backward shift of the spinal cord after you decompress the spinal canal. This is recoverable, yes. But if you make it iatrogenic or you lift it not very well decompressed, this is not going to be recovered, because you have to be generous in doing decompression at C5 from the beginning. Thank you.
Thank you, Professor Mazid, for your nice comments. I can remember Professor Mazid visited me during my fellowship in Japan, and it was amazing times and nice times. We spent 2 weeks together there. It was 3 months fellowship with Akio Moriyama. It was in 2005. Yes. 2005, yes. Professor Mazid. Yes, thank you.
Yes, yes, I remember. Thank you.
The big fish, Dr. Mazid, if you can remember it.
Yes. You ate it in a second, Muhammad.
Ahmed, do you have another case, or that's all for today?
No, that's all for today. Again, the C5 is a short nerve root, and as we mentioned, posterior shift or translation of the spinal cord after decompression is the main factor why C5 palsy happens. Personally, I haven't seen it in laminoplasty. I've did, many. I've seen it more with posterior cervical laminectomy. I try to do, again, generous from anatomy, but again, this nerve root is, you cannot expect what's going to happen. C5 is, it will be تلكك يعني, مجرد just to touch it, you stop working. And again, it happens with everyone. Luckily, it is recoverable, and again, the 3 patients I had have complete recovery of their C5. Yeah.
Dr. Hamdan Abdurrahman, do you want to add something regarding C5 palsy? You opened the discussion regarding it, and you can close it as well. Kindly unmute yourself. Hamdan. Hamdan.
Hello, assalamu alaikum.
Wa alaikum assalam.
There is a recommendation or expectation of C5 palsy preoperative. The foraminal diameter is important, the spinal canal EB diameter, and there is an angle between the cord and the lamina, cord-lamina angle. When it is acute angle, you can expect before the surgery C5 paralysis preoperative, and when we can do the surgery anterior, it is better to avoid this complication. I think so.
Hamdan, can you share this paper with us? Can you send it to me kindly?
I will do this.
Okay, great. Thank you, Hamdan.
Okay, thank you.
And send us this paper. Dr. Yusri?
Ahmed, thank you very much. You enrich us with the 3 cases. There are a lot to learn from them. And you are always amaze me. Thank you very much for this webinar, and have a nice Eid, and you and your family. Thank you very much.
Thanks for having me, and يعني كل سنة وانتم طيبين جميعا، وإن شاء الله ربنا يحفظكم ونشوفكم على خير بإذن الله.
شكرا جزيلا، ونشوفك على خير إن شاء الله في other flying spine surgeon Egyptian flying spine surgeons episodes. شكرا جزيلا دكتور أحمد.
شكرا محمد، شكرا جزيلا. كل سنة وانتم طيب.
كل سنة وانتم طيب. كل سنة وحضراتكم طيبين جميعا. Happy Eid for everyone. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.